So welcome to Understanding Bladder Preservation Therapy with Trimodality Therapy. This is a patient insight webinar from the Bladder Cancer Advocacy Network. We'd like to thank Bristol Myers Squibb, the EMD Serono Pfizer partnership, Ferring, Genentech, Photocure, and Merck for their support of the Patient Insight webinar series. My name is Stephanie Chisholm. I'm the Director of Education and Research at Beacon. I'm joined today by Columbia University urologist Dr. James McKiernan and Massachusetts General Hospital radiation oncologist Dr. Jason Astafiew, and they're going to discuss bladder preservation. Welcome, doctors. It's a pleasure to have you with us.
Thanks, Stephanie. Pleasure to be here.
Yeah, pleasure to be here. Thank you.
Super. Let me first introduce our speakers. Dr. Jim McKiernan is the John K. Latimer Professor and Chair of the Department of Urology of the College of Physicians and Surgeons and Urologist-in-Chief at New York Presbyterian Columbia University Hospital. Dr. McKiernan graduated from Johns Hopkins University with a BA in biology and received his medical degree from Columbia University College of Physicians and Surgeons. He specializes in urologic oncology, particularly surgical therapy in high-risk patients with bladder and kidney cancer. Dr. Astafiew serves as the director of the Genitourinary Division of Radiation Oncology and clinical co-director of the Claire and John Bertucci Center for GU Cancer's multidisciplinary clinic at Mass General Hospital. He holds a BS from Yale University and an MD from Harvard School of Medicine and a Doctor of Philosophy from Oxford University. He completed his residency training in the Harvard Radiation Oncology program. Dr. Astafiew's clinical practice focuses on the treatments of patients with bladder cancer and other urologic cancers. So I am going to turn the screen over to Dr. Astafiew. So you should be able to advance.
Great. Thank you, Stephanie, and it's a pleasure to be on this webinar and really appreciate all the attendees for taking the time to discuss this topic of trimodality therapy for bladder cancer. If I start by discussing some issues surrounding radical cystectomy. So as I was saying, a radical cystectomy is an excellent treatment for bladder cancer. And by no means is this presentation today meant to refute that point. It's just to show that there are options for patients. Now, these options may not be for everybody, but for those patients that are candidates for trimodality therapy, it's an option worth discussing and knowing more about. Next slide.
It's not allowing you to change it?
It wasn't, yeah.
Okay, one sec. Let me try again.
So there has been a paradigm shift in the world of oncology, and organ preservation has become much more commonplace these days. Listed here are a number of cancers where organ conservation is commonplace, such as in head and neck cancers, anal cancer, breast cancer, esophageal cancer, and limb sarcomas. So the question is, why hasn't that become common with bladder cancer yet? And we'll get into that a little bit in this talk. And one of the important things to note is that cystectomy, although again an excellent treatment and many patients do very well with a cystectomy, it can be life-altering. So this slide here shows some data from the Memorial Sloan Kettering Cancer Center, which is a very high volume center doing lots of radical cystectomies each year. And they honestly reported their complication rates following such a treatment, where 64% of patients had more than one complication, and 13% of those were what we call high-grade complications, grade 3 to 5. A quarter of patients required readmission after a cystectomy for management of complications. And there was a non-negligible 90-day mortality rate associated with a cystectomy as well. The Memorial Sloan Kettering also ran a study, a trial that compared doing an open cystectomy or a robotic-assisted cystectomy, and the results from their study suggested that there weren't any major differences between those different types of approaches to doing the surgery. So the question is, how golden is the gold standard of cystectomy, given that there is some perioperative morbidity associated with it? In addition, there are some other potential longer-term issues. Number one, recurrence rates in the pelvis after a cystectomy are not necessarily low, and late complications as well are not low. And so in this next slide, I highlight some studies that were run at the University of Pennsylvania and confirmed within a cooperative group, national cancer group called SWOG, that showed that pelvic recurrence rates, recurrences within the pelvis, could be as high as 40% in some patients after cystectomy. And other studies have suggested that in the long term, many patients suffer from renal or kidney function deterioration over time, with some patients progressing to very significant renal dysfunction over time. The other important point, and this is really important, is that cystectomy is not being performed in about 50% of patients who have muscle-invasive bladder cancer in the United States. So the average age of a bladder cancer patient is in the early 70s or late 60s, so they fall right into this group here. And as you can see, 50% of patients in that group are not receiving a cystectomy nationally for muscle-invasive bladder cancer. And the question is, well, what treatment are they receiving? And I can tell you that that gap is not being filled by trimodality therapy at this time. And so there is really a huge unmet need. And there's a real opportunity for trimodality therapy, chemoradiation, which we'll get into shortly, to fill that gap. So let's discuss trimodality therapy a little bit further. What is it? Well, I think the first important thing is to recognize that it's very much still a surgical approach. Although it is not a radical cystectomy, a maximal complete transurethral resection of the bladder tumor, the TURBT, which can be done with through a cystoscopic approach with a cystoscopy, is critical. And those patients that have good complete resections do better. Then that is followed by chemoradiation. And there are different ways of doing chemoradiation, so don't get confused by this slide. But basically, we go to a dose in terms of radiation dose that's known to be potentially curative for bladder cancer. The urologist is represented by a U here, showing that they remain very much a quarterback of this approach and are involved at different stages, including doing another cystoscopy and a rebiopsy of the area of the tumor following chemoradiation. For patients who are doing well and have had a complete response after chemoradiation, they go on to surveillance. And surveillance means lifelong cystoscopic surveillance, that in the first year or so is done every 3 months, then the intervals will decrease to every 6 months, and eventually yearly cystoscopies. If ever there is a recurrence of muscle-invasive bladder cancer in the bladder, then a salvage cystectomy could be considered as a backup. So a patient, so a tumor that has recurred and obviously wasn't cured by the chemoradiation could still be cured by doing a cystectomy if needed later on. What we know is that, again, that transurethral resection of the tumor and the salvage cystectomy are key to the success of trimodality therapy. Here, we've looked at the results from the Massachusetts General Hospital stratified by whether or not a complete TURBT in red was achieved or not in black. And as you can see, the outcomes are better if a complete transurethral resection is attainable prior to starting chemoradiation. Here we see some long-term results of trimodality therapy. And so, for example, the 5-year survival rate from bladder cancer approaches 75%. And this is in patients going back to the 1980s. So this is very long-term data. We would also argue that our data these days in the contemporary era are even better. So a patient with a T2 muscle-invasive bladder cancer could expect 5-year survival rates of bladder cancer approaching 75% and 10-year rates on the order of about 66%. So let's look at the outcomes of trimodality therapy a little bit closer. Here are our results shown in the contemporary era. And what do I mean by that? I mean patients treated since 2005. So basically the last decade or so. How are those patients doing? Well, the 5-year rate of surviving bladder cancer is now approaching about 85%. So I think our treatment has gotten better. Our ability to select patients that would do well with this have gotten better. The radiation's gotten better. The chemotherapy's gotten better. Emphasizing a complete transurethral resection has gotten better. And with that, we're seeing some very promising results with this approach. In addition, the need for a cystectomy due to a recurrence of the tumor in the future has gone way down. Back in the 80s, it was almost as high as 40%. Nowadays, it's more like 15%. And if we look at other studies as well in other series, I think a fair number to provide is 10 to 15% of patients may require a cystectomy following chemoradiation due to a recurrence. So what's the flip side of that? Well, about 85% of patients who've gone through trimodality therapy these days will retain their native bladder in the long term. Some folks ask, well, what if the bladder cancer was a urothelial carcinoma, which is the garden variety, most common form of bladder cancer, but what if it has a little bit of squamous differentiation or some other pathologic features like that? Can you still do trimodality therapy? And the results of this study suggest that yes, that survival rates appear to be pretty comparable, even if there is a mixed variant in the pathology. So how do these results of trimodality therapy compare to the gold standard of radical cystectomy? Here is a large series of radical cystectomy showing survival rates in the long term, and what you see is that the 10-year rates of survival are about 60 to 66% survival from bladder cancer, and that applies to T2, T3 tumors, and these are mostly the tumors we're talking about when comparing to trimodality therapy. So that's why I'm focusing on this sort of orange and green line. And if you recall, the 10-year rate was 66% with trimodality therapy as well. So we think that these results are pretty comparable to radical cystectomy. There are some studies, though, in the literature that use large national databases that have gotten some press that suggest, no, cystectomy is better than trimodality therapy in terms of survival in the long term. But you have to, we suggest caution in the interpretation of these types of studies, because these types of studies that use large national databases like SEER or the National Cancer Database are fraught with issues. For example, they are not just looking at patients who were, so they're including a lot of patients that were unfit for surgery. So surgery was never going to be an option due to either age or medical comorbidities. Those patients were not excluded, and so those are the patients that are certainly not getting surgery and may do worse in the longer term. In addition, studies like this have shown that inadequate radiation was delivered, and so a lot of patients who were receiving either inadequate radiation or perhaps palliative radiation, so not radiation that was designed for cure, are again included in these kinds of studies. So we just offer some caution for some of the studies that are out there. If we want to look at the best available studies comparing trimodality therapy to cystectomy, we can turn to a recent publication from the Toronto group, where they had actually established a multidisciplinary bladder cancer clinic where all patients saw the different specialties in the same setting, and were offered, for those that were candidates for cystectomy or trimodality therapy, they were offered either, and some would choose one and others would choose the other. And then those patients were followed and they were matched. So they had similar types of tumors, they had similar age, similar comorbidities, etc. And these patients were followed. And as you can see here, trimodality therapy in yellow and radical cystectomy in blue were not different in terms of survival. In the 5-year disease-specific survival from bladder cancer, again, was not statistically different between radical cystectomy and trimodality therapy. And you'll recall these 5-year numbers were very similar to the MGH results of 75% that I had shown earlier. Again, in the contemporary era, our results may even be better, as I had also shown earlier. But basically, I think this is the best available data comparing trimodality therapy to cystectomy in matched patients that were kind of equal to begin with. There are other studies out there. There's a way of kind of pooling a bunch of studies together called doing a meta-analysis. We don't need to get into that in any great detail other than to suggest that survival looks similar when you pool a lot of studies trying to compare these different treatments together in terms of overall or survival from bladder cancer. Now, an important part to the paradigm of trimodality therapy. So why is it called trimodality therapy? Well, one treatment is surgery, right? The transurethral resection, the TURBT, that's critical. And the potential 10 to 15% chance of a salvage cystectomy for backup. So that's one part of the trimodal treatment. The second part is certainly the radiation, which is treating the bladder. It's sort of replacing surgery. And then the third part of trimodal is the chemotherapy that goes along with the radiation. It's called radiosensitizing chemotherapy. It's low-dose chemotherapy that gives extra bang for the buck to the radiation. And that is an important component. This study here that was run in the UK looked at doing radiation alone, so no chemotherapy, versus radiation plus chemotherapy in red. And as you can see, whatever line is on top means it's doing better, and the chemoradiation arm was better than the radiation arm. So, and here's another study run here in the United States in one of the cooperative groups looking at different types of chemotherapy with radiation, showing no big differences between those types. So different forms of chemotherapy can be used with radiation. And this next slide lists those options of good radiosensitizing drugs. Cisplatin is a classic standard, probably the one that has the most data over time. Paclitaxel, 5-FU and mitomycin C. I'm going to show you that was the one that was used in this study here from the UK that I showed you. Gemcitabine, very low dose gemcitabine. And then there's even these drugs called carbagin and nicotinamide, which are hypoxia reducing drugs that tend to work well with radiation. Hypoxia is when there isn't sufficient oxygen in the tissue that you're treating, and these drugs reduce that and therefore make radiation more effective. The other important point here is there's lots of options for patients who are not candidates for cisplatin chemotherapy, because cisplatin chemotherapy requires good renal function, and a number of bladder cancer patients don't have good renal function. So the good thing here is there's a lot of other good options that can be used in that type of scenario.